Hello, friends and colleagues from the US and across the world. This is an honor to be at WooMedi webinar conference, and I'm really excited to be partnering with them. We create content for them every month. Our webinar is called American Heart and Vascular Institute, and so far we have done three, and we really invite you to go and check it out. We have world-class faculty from around the world. Today, I'm going to talk about a very important topic, and the one thing that I hear consistently from the cardiology fellows and the medicine residents that we don't get taught about business of medicine. And I think at the end of the day, it is on us. We should strive to learn about the business of medicine because it is not only going to impact our own practice, but at the end of the day, it also impacts the quality of care and overall the healthcare cost. So today's topic is implications of the new ambulatory payment model for percutaneous intervention. I have no financial disclosures. Before we get into this critical topic, let's take a 30,000 feet overview of the US healthcare and where we have been and where we are going. Compared to any developed country in the world, United States, we spend about 17% of our GDP on healthcare. That amounts to about $4 trillion every year. And at this rate, by 2030, we will be spending about 35 to 40% of our GDP on healthcare, which of course is not sustainable. And we also spend the most on administrative costs per capita compared to any other country. And also we spend, almost the lowest per capita on long-term care compared to any other developed country. And if you look at our budget, Medicare or the US budget, we spend the most on healthcare when you combine the Medicare spending, the Medicaid, ACA, even more than Social Security, even more than our defense. Ever since Affordable Care Act back in 2009 and 10, there has been a pernicious growth of hospital mergers and acquisitions. And if you look at the numbers, the operating margins of the hospital since then have been going up every year. If you look at the stock exchange, all these private insurance like United Health and Blue Cross Blue Shield, their shares have been exponentially going up as well. And you would think that by doing hospital acquisition and mergers, you would think that it would decrease the healthcare cost, it would improve the quality of care. But we will talk about how that has impacted our healthcare. But because of that hospital merger and acquisitions, now they are getting paid more for the same type of service that we provide in the office. For example, echocardiogram, nuclear studies, or for that matter, any procedure, the hospital gets paid 3 to 4 times more than it would be paid in a privately owned entity. So because of that reason, there has been acquisition of cardiology practices, primary care practices by these big hospital corporations. Right at this moment, about 73 to 75% of the cardiologists or practices are employed by this big hospital system, and only 25 to 27% are in private practice. And as you can see in this graph, that after mergers, how all the referrals starts going in-house compared to outpatient. So it's very hard to sustain your practice in outpatient setting. But let's look at this data. I mean, has this all mergers have improved the quality of care? The answer is no. This NAGM article, which was published earlier in 2020, there has been no improvement in quality of care, no changes in readmission mortality rate, decreased patient experience or satisfaction. It has exponentially increased the healthcare cost. And of course, if you talk to any physician who's employed, the physician satisfaction is also not there. So the great RPG, I love this quote from her back in 2017. It says, she says, a great person once said that the true symbol of the United States is not the bald eagle. It is the pendulum, and when the pendulum swings too far in one direction, it will go back. So that CMS, after Affordable Care Act, which encouraged this hospital merger acquisition, now it's coming back. It's coming back to its senses, and it's like, why are we doing it? Why, for the same echo or for the same vascular procedure, heart procedure, we are paying the hospital 3 times the more? But now it's trying to institute, again, it's very important, institute the site neutrality, which means that it is trying to level the playing field, where it could eliminate the incentive for hospitals to acquire physician office-based practices. And of course, the American Hospital Association is mostly against it. They are suing the CMS for it. But by just instituting this site neutrality rule for payments, the CMS will save almost $1 billion in 2020. So they are suing, the case is in the court, see where it'll go. But again, the CMS is finally, their mind is in the right place. So let's go back to the reimbursement for percutaneous cardiovascular procedures. Before we get into that, let's look at some basic concept, how the CMS pays. The CMS pays based on the service location. Now, for these cardiovascular procedure, if the service of location is office-based cath lab, it's called POS 11, point of service 11. If it is ambulatory surgical center, it's point of service 24. Outpatient hospital is point of service 22, inpatient is 21. Ever since the CMS approved peripheral vascular procedures and intervention back in 2010-11, there has been a growth of office-based lab since then. And right now, most of these vascular procedures are performed in those OBL. So what is the OBL, office-based lab, or point of service 11? Is basically an extension of a physician office. The ambulatory surgical center 24 is a freestanding facility. And OBL, there are not a lot of strict requirements to build these out. And most of the state, they don't need certificate of need, while the ambulatory surgical center are licensed by the state, regulated by the state. Some states require certificate of need. I'm in Utah, we don't need certificate of need for ASC. And then it also required medical deemed status to receive reimbursement from Medicare. What are the cardiovascular procedures that are allowed in these 2 different settings, or combination of these 2? Is mostly low risk procedures, which are associated with low risk of complications, no overnight stay, and the transfers are unlikely. Again, most of the peripheral vascular procedure, excluding carotid stenting and PVAR, can be performed in office-based lab. We can do the diagnostic coronary angiogram, intravascular ultrasound, venous intervention, and tons of other procedures as they are mentioned here. While in the ASC, you can pretty much perform everything that you can perform in the office-based lab. Plus, you can also do the cardiac intervention. You can do coronary stenting. You can also do pacemakers, BIVs, and ICDs. And then I'm not even including all the other surgical procedure, orthopedic surgery, spine surgeries, and plastic surgery, ENT, GI procedures that can be performed at the ASC. So what are the benefits of these procedures or these type of settings is patient satisfaction. They don't have to go through 10 different people to get to their doctors or get to their procedures. Lower risk of infection, less wait times. There's a dedicated staff. You have to handpick your own staff. Efficient, ease in scheduling, walk in from parking area, and it decreased the out-of-pocket expense for the patient. And of course, we will see later, it also decrease the healthcare cost. So anytime when you perform procedures in the office-based lab, the overall reimbursement is almost 20-25% less than the hospital-based setting. So that's a huge saving there. So let's look at the reimbursement for different procedures in different settings. Again, if you look at if the cardiovascular procedure is performed in the hospital or hospital outpatient or ASC, so there are 2 types of reimbursement: technical fee and the professional fee, which is called the physician fee. If these procedures are performed in the office-based lab, there's no separate facility fee and a physician fee. It all lump sum under Medicare physician fee schedule. So let's look at peripheral vascular procedure. In 2018, About 37% of peripheral vascular procedures were performed in hospital outpatient, about 34% in OBL, and in the ASC, very small amount, but those numbers are increasing. In 2020, I bet this is almost 60% or more in the office-based lab. But the trend is changing. If you look at the reimbursement in 2020, for example, the SFA, peripheral angiogram, atherectomy, and stent, office-based lab gets paid $14,000 reimbursed. The ambulatory surgical center is 10,000 or 11,000, but look at it's 5.7% increase. So the Medicare is slowly pushing this towards ASC. And then the outpatient is 15,000. So even if you perform in the ASC, you save Medicare about $6,000. And the same goes for tibial atherectomy and stenting. It's more an office-based lab, but the trend is now going more towards ASC, but much lower than the hospital outpatient. Same goes for AV fistula work. They get reimbursed very well in the ambulatory surgical center, much lower than the hospital setting. So you see the huge trend of these AV fistula or dialysis access types of procedures moving in the ambulatory surgical center. The venous work is the same story. Now, this is very important. Coronary angiogram, the diagnostic coronary angiogram. If you do diagnostic coronary angiogram, most of these, are already performed in the hospital outpatient setting, and the reimbursement is almost $3,000. But you are seeing this huge trend now moving towards office-based lab and the ASC. It's about 1,300 in ASC compared to 900 in office-based lab, but still much lower than the hospital outpatient. This is big, the coronary stenting, the Medicare in 2020, the CMS approved PCF single vessel in the ASC setting. And we already know from 2018 data, about 43% of these single vessel PCIs are performed in the outpatient setting, or not single vessel, but the overall PCIs are in outpatient setting. And I see this huge shift of these outpatient hospital-based PCI moving towards ASCs. The reimbursement in the hospital is almost $10,000. In the office, in the ASC, is about $6,000. So it's almost a half, and they're not reimbursed in the office-based lab. And again, just trying to emphasize the point that the trend is now going from the office-based lab into the ASC. And in the ASC, not in the office-based lab, in the ASC, you can also put the pacemaker, dual chamber. The reimbursement is about $8,000, and for the single vessel ICD is $20,000. And we will see more and more of these in the ASC setting. Again, you can have combination of ASC and OBL, which is kind of the hybrid model, where you can use for a few days as an OBL, and for other days you can do ASC just for the reimbursement purposes. But again, it will be a good idea to going forward to kind of focus more on the ASC part than just the OBL part. And there are multiple projections that by 85%, by 2028, 85% of all healthcare procedure will be performed in outpatient setting. This is because of the exponential growth and improvement in technology in orthopedics, cardiology, and spine. And if you look at, again, the data from 2011 and 2018, the ASCs, the ambulatory surgical center, have saved Medicare about $12 billion. By 2028, even in that 1 year, the ASCs will be saving Medicare about $12 billion. So the tide is changing now. And this is a simple pro forma that you can punch in numbers based on your type of practice, your partners, whether you have IR and surgeons in your practice. And again, in this pro forma, I'm not even including the cardiovascular procedures or pacemaker ICD, just the peripheral vascular fistula work. And you can look at the operating margins are about 50%, and the profits are about operating income after taxes about $2 million every year. Again, I'm not including any spine surgery, orthopedic surgery. So this is very lucrative for the physicians and the partners and for the patient. So the OBL ASC or the hybrid model has arrived. It's the same operator, same procedure, same equipment, same result, at much better patient satisfaction, quality care, and saving cost. Um, my uh, humble predictions going forward is especially after COVID-19, that more and more cardiovascular care will be virtual and home based, or if they need some sort of cardiovascular procedure, most of them will be performed in the ASC, and the less care will be delivered in big box healthcare facilities. And then primary care and multidisciplinary or multi-specialty provider groups more likely will seek on capitation type of model for reimbursement instead of pure fee-for-service going forward. And this is my favorite quote by William Ward. The pessimist complain about the wind, the optimist expects it to change, the realist adjusts sail. And this is the high time for us to adjust our sail. Again, thank you so much for this invite on behalf of New Cardiovascular Horizon. We invite you to join us at Salt Lake City, February 2021. This will be a one-day CME conference. We'll talk about 20 to 25 different topics, high yield, 5 minutes each, and we would love to see you there. Thank you.